For our last talk, it is me. Thank you. That was nice. Featuring, because I am a rapper, Brady, the speech-language pathologist. So I wanted to talk about trauma for primary care providers for a couple of reasons. This is a little bit of a gratuitous plug so you guys know what we're doing over in the trauma clinic. There's really two topics that I wanted to talk to you about. I want to talk about rib fractures and I want to talk about concussions, because those are two of the most common things we see that people don't really know what to do with. So rib fractures, kind of the care of rib fractures has evolved over the years. I pulled this article from the Journal of Trauma and Acute Care Surgery because I thought it was really important to talk about what's currently happening and how we treat rib fractures. This paper is called Non-Surgical Management and Analgesia Strategies for Older Adults with Multiple Rib Fractures. I know that Dr. Kaiden mentioned, Dr. Lysette mentioned that 54% of our population here in Boulder are geriatric patients. Most of them are falls, and a lot of them have rib fractures. And so we were talking about how do we take care of these patients so that they make it out of the hospital and are successful afterwards. Rib fractures are the most serious injury. 55% of the patients over the age of 60 who die following a motor vehicle collision have rib fractures. Morbidity and mortality is due to pain induced by hypoventilation, pneumonia, and respiratory failure. When I chat with patients, I always tell them people don't die from rib fractures, they die from pneumonia. They can't get deep enough breaths, they get sick, and then they die. Nobody dies from rib fractures, they have a lot of pain from it. But really it's the side effects of the rib fractures that increases the morbidity and mortality. And then frailty screening in major trauma is now financially rewarded and should drive geriatric engagement with major trauma. I'm gonna say that again because that's what we're all about this year in trauma. Frailty screening in major trauma is financially rewarded and should drive geriatric engagement. In patients greater than 65, each additional rib fracture increases the risk of pneumonia by 27% and the risk of death by 20%. This doesn't really seem like a sexy topic, but when you're talking about mortalities of this magnitude, we can change how we treat these patients and really impact a lot of people. Rib fractures are a surrogate for major trauma, with 90% of patients having additional injuries. Geriatric patients with rib fractures have a 2 to 5% greater mortality compared with those patients under the age of 60. I found this on Amazon. They are still selling these. I will tell you that I have probably 2 to 3 patients a week come into the clinic and say, oh, I just wrapped up my ribs. We used to do that. Anybody around for the wrap up my rib days? Yeah, we don't wrap up our ribs anymore. Why? Because then people aren't taking big, deep breaths, they're not expanding their lungs, they're getting pneumonia, and they're dying, right? So I routinely have to either take these off of people and be like, oh no, don't do that, or tell them, don't buy this thing that they sell on Amazon for $13 because you have rib fractures. How many people have sprained a something and bought a something off of Amazon? Yeah, totally, I do it all the time. You know, if me as a physician am buying things off of Amazon because I sprained a something, the general population is buying stuff off of Amazon because they've got rib fractures and they hurt, and they're like, oh, I'll just bind them up. How many people know what an incentive spirometer is? Oh, good, everybody. So let's talk about the incentive spirometer because I really love it. It's one of my favorite tools. How many people have seen the little piece of paper in the incentive spirometry package? How many people throw that away when they hand the patient the incentive spirometer? Yeah, totally. This is a paper that was published in 2019. Using the incentive spirometer reduces pulmonary complications in patients with traumatic rib fractures. So the thesis of this, they looked at 50 patients with traumatic rib fractures. This was a prospective study. The patients were randomized to 2 groups. All the patients received the same analgesia. They got a chest x-ray and then checked their pulmonary function at day 5 and 7. 56% of all patients developed pulmonary complications, which was more prevalent in the control group. 80% pulmonary complications in the non-IS group compared to 29% complications in the IS group. PFTs showed decreased forced vital capacity and forced expiratory volume at 1 second in the control group. Comparing pre and post treatment FVC and FEV1, the study group had significant greater improvement. So IS does work. How many people see patients that have an IS sitting in their room and they don't know what to do with it? How many people see patients that have an IS sitting in their room and they have maybe 2 or 3 of them? How many people see the IS machine and the patient try to use it and the patient does this? Right. So we have this tool and we don't really know what to do with it. And then, do we have this tool at all in the pre-hospital setting? Not really, right? So the primary care doctors are not using this at all. I will tell you that I use IS on every rib fracture patient to make determinations on where they need to go in the hospital, on how well they are progressing, how well I'm doing at pain management and control for them. And so it's interesting to me that we have a tool that we know can improve outcomes, but we also are not really using it to gauge where our patients are improving or what we need to do to help them improve. Spirometry, not pain level, predicts outcomes in the geriatric patients with isolated rib fractures. I thought this was a nice study too. FVC has been shown to correlate with outcomes in patients with rib fractures. In this study, they had 86 patients greater than 60 with 3 or more isolated ribs. The patients were assessed on the happy face, sad face scale. Their grip strength, their FVC and FEV1, and their negative inspiratory force on hospital day 1, 2, and 3. Their primary outcome of the study, they looked at discharge disposition, length of stay, pneumonia, intubation, and unplanned ICU admission. FVC, FEV1, and negative inspiratory force and grip strength, which is one of the things that we use as a surrogate to assess frailty in patients, all predicted early discharge for the patient home. Change in pain did not predict outcomes, and pain level was not associated with respiratory volumes. FEV1 remains the significant predictor to discharge home and lower length of hospitalization. This is the paper that you throw away when you give the patient the IS. So if you will look on here, we can use me as an example. I'm age 45, and I am 62 inches tall. And so my expected IS level should be 1850. How many people are like, here's an IS, you should be doing 2,000 on it? Right? We just tell patients, oh, you should be at about 2,000. It's different for everybody, and it's different based upon your age and your height. So really, if I was your patient, you would say, I would expect you to be at 1850 for your IS volume. If a patient is not controlled on the above, I don't know where that slide came from. Disregard that first sentence because that doesn't go there. If the incentive spirometry is not greater than 70% of the predicted value, patient should be admitted to the hospital for pain control. So if my IS is not 1850 or 70% of 1850, there's math in there somewhere, then I should be admitted to the hospital for pain control. We use this technique when we come and see patients in the emergency department. It's really easy to say, oh, this guy really looks great. He's got 4 rib fractures, he's 82, but he is super happy and wants to go home. The first question I always ask is, well, what's his IS? Because inevitably, Pappy looks great, but then when you make him breathe into the breathing toy, he's like, I can't breathe. And that's our indication that he probably needs to come to the hospital for pain control. This is what goes with the sentence beforehand. We try a multimodal approach to pain management. So, there's lots of receptors that control pain. If we target just one receptor, we're missing a whole slew of opportunities for pain control. Tylenol, ibuprofen, Oxycodone or Ribaxin, we typically don't prescribe both as a first line. How come? Gravity? Gravity, yeah, you're right. And lidoderm patches. We don't prescribe both because the combination of sedatives and opioids increases your risk of respiratory depression by 5-fold. So you have a 5 times higher risk of dying if you're taking oxycodone and a benzodiazepine at the same time. So what we do when we talk to patients before they leave, and everybody's a little bit different, we say, hey, which drug worked better for you? Okay, let's do that. But we do not send patients home on a benzodiazepine and a narcotic because the risk of respiratory depression is so high. Do we get chest x-rays on these patients? When do we get chest x-rays on these patients? Rib fractures? If their incentive spirometry is decreased, I'll repeat their chest x-ray. So I use IS as a functional tool every day. Hey, where is your IS at? Okay, you're in a good place today. We're making forward progress. If they're on anticoagulation, those patients will always get a follow-up x-ray because your risk of rebleed is a lot higher. Sometimes you break a rib, you tear one of those little intercostal vessels, it spasms so you don't have initial bleeding, but 24 hours later, you may have a hemothorax. And so if a patient's on anticoagulation, I'll typically repeat a chest x-ray. If they have multiple rib fractures, I don't want 1 point of time imaging. I want at least 2 points in time imaging. If they're hypoxic, that one's a little obvious, repeat your chest x-ray. If they're asymptomatic and don't have any of the above, and they have a rib fracture or 3, don't repeat the chest x-ray, they're fine. You don't need to continue to do repeat imaging. Should you always get a CT scan in patients that have x-ray findings of rib fractures? Yes, yeah. Christy's saying yes. I'm saying yes, Christy, you're right. Yeah, you know, there are so many hidden things with rib fractures. Remember I was talking about the geriatric patient that 60% of them will have concomitant injuries that you likely will not catch if you're just getting a plain film chest x-ray. So anybody that's got plain film rib fractures, I will always get a CT scan in them to make sure that I'm not missing another injury. You have to think about more common splenic injury if you have rib fractures of like 8, 9, 10 on this side. Liver, but not so much. Spleen just kind of gets bonked more than liver. So you always are worried about if you have lower rib fractures, you want to make sure that the organ underneath is not also affected. What do you do with flail chest? I have like my own personal emoji right here. Christy just keeps making all the faces at me. She said, yes, that's what you do with flail chest. So a flail chest is 2 or more rib fractures of the same rib. So you have a rib that's broken in more than one segment. Dr. Platnick stepped out of the room, which is good, because he and I maybe don't agree on this. Stabilization or no stabilization is the question. Denver Health is one of the leading centers for rib fracture stabilization in the country, so he is very likely, you can ask him, very pro-rib stabilization. My opinion on it, after reviewing the literature, is that if you have significant chest wall deformity and it is impairing your mechanics, it might make some sense to do rib plating in order to liberate someone from a ventilator or to recontour their chest. So I will say over the years there's been, I don't know, probably 5 or 10 patients that I have said, yes, I think this patient would benefit from rib plating and have actually done rib plating. Denver Health does a lot more rib plating and early on. We'll see what the data shows in a few years, which modality is better. I would say generally most patients do better or get better without an intervention. This is a paper, Flail Chest Injury, Changing Managements and Outcomes. Oops, sorry, go back. The purpose of this study was to assess trends in the management of flail chest over time and to determine the impact on patient outcome. And what they concluded from this study of 720 patients was over the past decade, we've seen an increased rate in the use of regional anesthesia, so epidurals and junctional blocks, and surgical rib fixation in the management of flail chest. This has resulted in lower requirements for duration of invasive mechanical ventilation and intensive care stay, but has not impacted mortality on the patient cohort. I think in this study, the higher use of regional anesthesia was playing a role in that. Traumatic pneumothorax and the review of current diagnostic practices and evolving management. I really love this paper. It was presented, I think, at the Eastern Trauma Association last year, looking at the management of pneumothorax. When I first started training, anybody that had a pneumothorax and maybe even a tiny little blip on the CT scan, we immediately were like, we have to put a chest tube in this patient. And so we did, we put chest tubes in everybody. I think the pendulum has swung a bit, and now we are really much more comfortable with saying, okay, this is a small pneumothorax that the patient is hemodynamically stable. We maybe don't need to put a chest tube in that. So in this paper, they practiced 3 centimeters or less was okay to observe, and their overall outcome for those patients were really good. In these patients that I'm going to manage without a chest tube, early follow-up, and strict return precautions. First rib fractures. What we need to think about in first rib fractures, the first rib is really, really a tough bone and very challenging to break. And so if you have the force that is going to break your first rib, there's a very high likelihood that you're going to have an injury to your carotid or vertebral vessels. So we have adopted here the screening for blunt cerebrovascular injury. So when you have a patient that shows up in your clinic and they have rib fractures and it's a first rib as well, just think, oh, I need to screen for BCVI too. I'll jump to the end and say, you can also call me and I'll help you with it. That's all I have on rib fractures. Questions, comments, feelings? Ma'am?
Are there disadvantages to using nerve blocks as a controllable mechanism for patients with multiple nerve fractures?
Yeah, her question was, are there disadvantages to using nerve blocks for pain control? I suppose if you hit something while you're putting in your nerve block that you didn't intend to hit, but I would say the likelihood of that is probably pretty low. If you're putting an epidural in, you just have to be mindful of timing for VTE prophylaxis as well, based upon the axial anesthesia guidelines, but I don't think that there's necessarily any disadvantages, and certainly pain control is the significant advantage. Yeah. What else? Ma'am? Thoughts about pillow splinting? Well, I know that people like to hold on to pillows when they cough. That doesn't really offend me. I don't think that, well, I was trying to think, would I wrap someone in pillows? And although that may be pleasant. No, I mean, I think that if you need to hold on to something while you're coughing, that's fine. We certainly don't want to restrict the dynamics of chest wall expansion. What else? That was a fun question. Okay, cool. Let's talk about concussions. How many people see concussion patients and are like, what do I, Carla said me, what do I do with this? No? Okay. I will tell you, yeah, okay, I've got 3 people that are like, what do I do with this? I did not intend to be the concussion person when I came here. I didn't wake up in the morning and go, gosh, I'm really passionate about concussions. Let's dive into this thing, trauma surgeon. But what I found is that we have a huge need for guidance on what to do with concussions. And so I am, with the help of Brittany Hicks and Janina Corba, my left and right hand, clawing our way to becoming concussion specialists. And so I'm going to share with you a little bit of the knowledge that I've learned in the last year. Really today we're going to focus on the consensus statement on concussions, and this is the 6th International Conference on Concussions in Sport. They are in Amsterdam. This is the latest and greatest sports medicine guidelines for concussions, and it was published in 2023, first presented in 2022. In reviewing the literature, I have not really found great data for concussions when we're talking about trauma patients. There's really great data for concussions and sports medicine, and so a lot of the practices in the concussion and trauma arena are extrapolated from the concussion sports medicine arena. So these are sports medicine guidelines. So what is a concussion? It's a traumatic brain injury caused by a direct blow to the head, neck, or body, resulting in an impulsive force being transmitted to the brain. It's caused by neurotransmitters and a metabolic cascade, with or without axonal injury, blood flow changes, and inflammation affecting the brain, which kind of is just things happen up there in the brain, and we're not really sure what, but we know it's real. Symptoms may be present immediately, evolve over minutes or hours, or may resolve within a day, or be prolonged. For strict definition of concussion, there is no structural abnormality seen on neuroimaging studies. So can a traumatic brain injury also be a concussion? Yeah, so I think one of the things that I have found in having this conversation is people come in and they're like, but do I have a TBI? And the answer is sure. I mean, yeah, you're right, you do. But do I have a concussion? Maybe. So concussion is really the symptoms, right? So traumatic brain injury is kind of the catch-all phrase that we use for you got bonked on the head and something is not right. Now, that could be something that's not right. You have a little bit of a headache. That could be you have a massive subdural hematoma and we need to do something emergently about it. When we talk about traumatic brain injury, classically in the hospital setting, really what we're talking about is a brain injury that has structural CT scan findings that go along with it. And so I think that we actually had a conversation with one of our trauma survivors the other day, and she said, I feel like as an industry, you all, trauma surgeons, don't really put enough thought into concussion just because we don't have something you can't see on a CT scan. Something you can see on a CT scan, right? And she's right. We see probably 5 to 10 patients a week who have a constellation of symptoms, but no blood in their brain per se. I would say the blood in the brain patients are a little bit easier to manage because you know exactly what you're going after and treating, whereas the no blood in the brain patients but have clinical symptoms, it's a little bit up in the air. So let me tell you what we do with these folks. Some of the symptoms: fatigue, dizziness, vertigo, nausea, vomiting, emotional lability, screen sensitivity, headaches, nothing at all. Dr. Fox sent me this one day. He said, I thought of you when I saw this. Be a little chicken tender. Historically, what we have done with medication management, or is to take a multimodal approach again to the concussion patients. So we start with medication management because that's a doing thing that we can navigate, and then we focus on symptom management. So some medications that we often use: histamine blockers, caffeine, antiemetics, NSAIDs, propranolol, and amitriptyline are kind of my third line, something that I reach for if I can't get people symptom controlled. with histamine blockers, caffeine, antiemetics, and NSAIDs. For symptom management, how many of you guys have seen the handout, I don't want to know, have seen the handout that we hand out to patients in the hospital, we put on their room, and we say, you have a traumatic brain injury. You should not, Sadie's raising her hand, you should not have any screen time. You should keep the room dark. You should not have, yeah, okay, there's like 3 people, good job. 4 people, yeah. So those recommendations are kind of outdated, and we are working on updating those recommendations because the reality is that every concussion is a little bit different, right? I may hit my head and be nauseous and have headaches and nausea. You may hit your head and have sensitivity to screen time and emotional lability. So our approach has rather been not to say, don't do any of these things and sit in the dark and don't have any stimulation, but to say, hey, are you having sensitivity to screen time? Okay, do gradual return to screen time, or try it and then set it down and give yourself a break. Are you having nausea and vomiting? Great, here's some antiemetics. But it doesn't make sense to give somebody antiemetics if they're not having nausea and vomiting. So really, what we're trying to move towards is tailoring our approach to care to actually the symptoms the patient has, not just a blanket, don't do this statement. Does that make sense? Cool. Any Duolingoers out there? Did you guys notice last week that our Duolingo emoji got very angry? I was very sad. I have a new baby at home, and I told my husband I look like the Duolingo bird. But Duolingo bird is now happy again. So the point of the Duolingo bird is symptom management. So decrease noxious stimuli, brain rest when you need it, but that doesn't mean brain in the dark for 6 weeks. And then safety precautions, make good choices. We always talk about, with our patients, emotional lability, and that's a really real thing. And so I think that it's super important just to tell patients, hey, these are the symptoms you might have, and you might find that your fuse is a little bit shorter than it has normally been, and that's okay. Tell the people around you that this is what's going on with you, and so they can respond appropriately too. What if that doesn't work? Our practice is if symptoms persist beyond 4 weeks, we recommend outpatient therapies. Consider speech-language pathology, PT, OT, physiatry, sports medicine, consult neurologist, and then time. I like this, this logarithmic arc. And I actually kind of use this analogy with most patients that are trauma patients as they recover, that you're going to have good days, and then you're going to have bad days, and you're going to have good days, and you're going to have bad days. But you should, in general, be seeing that logarithmic arc or seeing an improvement in your symptom management. So if you are not, then we need to intervene. This is the return to learn strategy, which I think is super helpful. Again, 15 years ago in sports medicine concussions, they would tell patients, just no brain stimulation. And really what they're finding now is gradual tolerance of activities, and patients have better outcomes. The return to learn should be completed prior to considering return to play. So return to play is, again, gradual reintroduction of work or school. You start with light activity. If you do great with that, then the next day you do more activity. If you do great with that, the next day you do more activity until you're back to normal. You should not return to play until you have returned to learn. So if you have not accomplished the things on the first slide, return to your normal activities of daily living, then you should not return to contact football. Trauma patient, if you have not returned to your normal baseline self, you should probably not be out skiing again. Long-term effects of concussions. So there's been lots of studies that examine mental health and the outcome of former amateur athletes, and there's no risk for increased depression or suicidality in these patient populations, which I think is really important. This comes up more than you would think, and I think because there's so much press around chronic traumatic encephalopathy and the professional football players, patients are always ask me, if I had one concussion, what does that mean if I get my next concussion? What does that mean if I get my next concussion? The good news is that for the most part, unless you are a professional athlete, your mental health and risk of depression and suicidality should not increase post-concussion. The last facet of the Amsterdam recommendations is the retire. When do we stop doing what we're doing? And we get this a lot too. When should my kids stop playing high school basketball because they've had 2 concussions? I wish there was a clear answer. I wish we could boop, 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 boop in our little calculator and say, this is what you should do. But really the reality is shared decision-making and analyzing the risk-benefit ratio for that person and the impacts of either continuing to play or not playing, and then making some choices together. Okay, now for the best part of the presentation, Karen Brady's going to come talk to us about what they do in that magical place called outpatient therapy.
Did you put stuff in here for me? Oh, cool. Okay, green button. So outpatient rehabilitation, we're out in Lafayette, the CMC medical building. For those of you who don't know where we are, we have an interdisciplinary team of physical, occupational, and speech therapy. In my experience, when it comes to concussions, one of us will evaluate pretty much every patient. Every once in a while, there might be only 2 or 1 of us involved, but for the most part, the patients tend to see all of us for varying amounts of time for varying reasons. So with PT, these are kind of our main modalities that we're looking at. So vestibular rehab, do people know what a vestibular injury means? In here, everyone knows what that means. I don't have to talk about that. Oh, okay, so it's when some of the crystals in our inner ear are disrupted, and that's what maintains our equilibrium. So we have a lot of, with impact, those can be knocked out of whack, so to speak. So vestibular rehab is all about kind of calming those down, getting them back in place so that your equilibrium comes back. People can have vertigo, people can have dizziness. They do tend to look a little bit different. Gaze instability is a really big one. And I'll talk a little bit more about that. Oh, I forgot to bring my paper up. That's okay. And then just general imbalance. So an example is we're treating a patient who has been wearing the same sneakers for a really long time. She keeps falling from standing, as Liz Lysette talked about. And so one of the PT's recommendations was, well, buy some new shoes, bring them in, let's see how you walk, right? Well, a lot of new running shoes, walking shoes are super cushy, like the Hokas and the big cushy soles. And so she bought some new ones and actually looked worse in those. So PT is really looking at what are some other environmental factors that are going to help your balance. Are you carrying too many things in your hand when you're walking through the house, and that's why you fall, because you lose your balance and you don't want to drop what's in your hand. Craniosacral therapy is another modality that we use. We tend to have patients come to this specifically when their nervous systems are still really, really activated. We might see this more often in people with traumatic injuries from motor vehicle accidents, assaults, just things that really emotionally this event has really done, have been really challenging for them. And so sometimes those people can't really tolerate some of the more traditional vestibular rehab yet. They're way too symptomatic. Their headaches might be 8 out of 10 every day, even with medications. And they're kind of still in fight or flight from what happened to them. And so we do see a lot of people like this. And craniosacral tends to look at this, the supportive structures around the brain and kind of normalizing some of the inflammation and kind of disruptive tightness around those to help people kind of calm down, have a little bit more generalized feeling of okayness so they're not so overwhelmed. And really, when we look at nervous system activation, regulation, our whole team is working on that. We've had the benefit of education from a previous occupational therapist we had who was part of the pain management program. Her name is Sally Thomas. I don't know if anyone knows Sally, but a lot of work around if your nervous system is activated, you're not thinking well, you're not balancing very well, and everything will just kind of go out the window. You're just in that survival mode. And when we have people in therapy that arrive that way, we have to try to get that nervous system to get calmed down. And one of our tools is craniosacral. So occupational therapy, one thing that I really want to drive home is our vision rehab program. It is amazing. Patients are going to complain of headaches while reading, difficulty tracking. Some of our patients will not be really, when they're driving, they're kind of turning their whole bodies when they're looking around because they can't really rely on peripheral vision. So there's convergence and divergence deficits, saccadic eye movement deficits, and some of these are a little bit hard to suss out without that full vision evaluation. And this is different, obviously, from visual acuity. So we're not telling people you just need new glasses. This is more of a visual perceptual problem and how the eyes are moving together and communicating with the brain. And so we have two fabulous OTs that are really well versed in this. So even if your patients are saying, well, no, I mean, I can kind of watch TV or I can kind of read. A lot of those symptoms tend to be difficulty reading, headaches with reading, again, not really feeling like they're using their visual, peripheral vision very well. And also what happens is the eyes tend to sort of overwork, so their eyes are always tired, always tired. The Safe Driver Evaluation is a set of clinical tests and motor that look at cognitive, motor, perceptual tests that make sure people are still safe to be operating a vehicle. It is not an on-the-road test. A lot of times we will refer for an on-the-road after a safe driver eval if people perform sort of on the line. When it comes to concussion, some people tend to do this a little bit more as a, like, I would like to go through this to make sure everything's good. Maybe they have chosen not to drive because of their symptoms. They just want to do this to make sure that everything's looking good. Functional energy conservation, sort of like Laura was talking about, it's all about pacing. Gradual return. So yeah, we don't want people in a dark room for 6 weeks because that will lead to increased mental health symptoms and limited activity. So that's just not what we want anymore. But we do need people to pace themselves, and we do need people to understand that it's kind of like a hike up to the arc, right? Like you're going downhill sometimes, you're going uphill sometimes, but you're still going to get to the top. And complex activities of daily living. So this might be, getting back to work, paying your bills, being able to look at a screen long enough to accomplish something. A lot of our vision rehab folks really can't tolerate screens very long. So it's all about, and also like kind of strategies for reading. We make reading windows where you just have a little sliver in a folder to help you just look at less text on a page. And my favorite, speech language therapy. These are just a few examples of what we work on. I think the one that I want to really point out is this whole idea of metacognition. So we all have this sense of thinking about our own thinking. How does my brain work best under different circumstances? How do I learn best? How do I remember best? How do I run best? How do I do all the things that I do in the best way possible? And that really requires you to be thinking about, well, how does my brain work in that situation? And that's a big thing that I'm working with people on is if they are having trouble with memory, well, what is it, how are you trying to remember things? And how, if the old way is not working, how can we help you create a way that will work because you're really aware and intentional with it. So metacognition is a really big thing that we talk about, and how that relates to executive function, so planning, organizing. People might say, you know, I'm starting to feel better, but planning an activity with my friends, it just takes too much energy, right? So how do you work through that? People might be ready to go back to work, but not full time. And so we draft a lot of letters to a lot of employers saying, here's what we recommend. Let us know if you have any questions. And I will say personally, I've probably only had one employer come back and say we can't accommodate that. And I've probably written, I don't know, I've been here for 12 years, so lots of letters. So it's really interesting to see that a lot of employers will be supportive when they know how to support. Reading comprehension, generative thinking. So some of our students, you know, I can't write a paper anymore. I can't form a cohesive argument. We try to work on strategies through that. And a lot of this really has to do with pacing and energy. So people who want to just dive back in, they will bomb. So they'll have peaks and valleys with their energy and with their performance. And we're trying to get them to rolling hills. That's where we're trying to get them to be. Energy allocation, it's like a budget. How much energy do you have today? How much can you spend on this task and that task? And then where is your scheduled rest? And scheduled rest is really important because it's taking rest before overload. And when you have overload, no one's thinking. You might be in fight or flight. You might be asleep, right? But we have to get people from a place of, oh, I get overloaded after 2 hours. We've got to help them get a little bit better with more tolerance, greater complex activities, and that kind of thing. So Dr. Harmon has sent us a lot of people. I think our concussion clinic is really strong. We're one of the only places in Boulder County that offers all 3 therapies in one place for neuro rehab. And you know, if you're not sure what to do with someone, if it's been 2 weeks and they're still reporting cognitive problems, they're still reporting physical problems, please send them to us. Don't hesitate, just send them. Because most likely they will benefit from us even if they only see us 2 or 3 times. A lot of education that you guys may not always as providers or in the hospital have time to do. Also, when people are in the hospital, they're in a pretty controlled environment. When they come home, they're realizing, oh, I have to do this, but I gotta do this, and I gotta go here, and I gotta go there. And in the hospital, it's a little bit more controlled, like, oh yeah, you can have therapy now, here's your food, right? So they go back into their normal life and they're really overwhelmed with, what am I gonna do next? What's the most important? So we can really help with that. And sometimes some of these deficits don't show up in the hospital as strongly as they do at home because we have the signs up that say, please don't, and I'm not dissing the signs are there for a reason, but I think it's really important to always have an education follow-up around, well, what does this really look like in my home, in my real environment? Because it will always look different.
I mean, she teed it up perfectly. So I want to tell you a little bit about what we do in Trauma Clinic. Trauma Clinic is a bi-weekly clinic over at the hospital. It's staffed by me and Brittany and Janina, and we see, I would say, 10 to 15 concussion patients a week. Primary care doctors, you don't have to send your concussions to us. You certainly can if that's something that you don't want to manage, or that patient, you've hit your limits of what you were able to manage with them. By all means, please send them over to us. We are happy to see them. Lots of patients we see once or twice, and they move on about their life, and they never need Karen and her team. I would say probably about 30% of patients do, and I would say about 10% of patients really have ongoing symptoms for several months. And so what we provide for them is just medication management and just that consistent follow-up with a provider over the course of their concussion. And I think from a mental health standpoint, our patients that have gone through this process with our clinic really appreciate not feeling like they were alone in trying to get through this on their own. We are also there for all of your trauma and general surgery needs. If you have rib fracture patients, if you have patients that have pain following a trauma, if you have minor trauma evaluations, just send them over to us. We're happy to see everything. We also do PTSD screening and concussion screening. We have access to social work and help really the transition from trauma to getting back to my normal life, managing my trauma, and then the Trauma Survivors Network, which you've heard about earlier today. This is our Trauma Survivors Network page. There's more stuff on it even since this morning, so take a look at it. We're linked in through BCH. Questions, comments, concerns, feelings? Ma'am?
How young do you see patients in your trauma clinic?
Oh, I don't know. I think the youngest we've seen is about 14. Yeah. Any age is the answer, although I would say that there are probably, for true pediatric patients, better folks out there that we can connect you with. So if you have questions about it, send them to us and we can get them in the right place. Ma'am?
So when they're discharged from the ICU, I don't think they're getting this information to go to the trauma clinic. They have follow-up in your office.
Yes.
And you decide they're going to?
If we're going to send them to speech language pathology after that? Yeah. So used to, in the old days, I think like a month ago, Robin, we had a program where our in-hospital SLPs were calling all of these post-concussive patients that presented to the hospital in general. And I think Robin's predecessor, Allison, and I looked at it about a year ago and found that in 1 month we had 412 patients that screened for concussion that our therapist had reached out to and made contact with like 4 people. And so we thought, gosh, that's not really a great use of our efforts. So let's kind of restructure how we're doing this. So we are reworking our approach to concussions at BCH overall. You guys just got the first taste of it today. Robin's partnering with us on doing that as well. Yes, ma'am.
I'm not sure if Karen or maybe the answer. Is therapeutic stimulation a term we want to be using with patients? Because I feel like there's different associations with that. And the way you describe like rehab and introduction back into life is my idea of therapeutic stimulation. But I think there's some confusion with the terminology. So I'm just wondering if you can speak to that a little bit.
Karen, do you have an opinion?
I think the term in and of itself can be a good term, but I think the question is, how are we educating the rest of the hospital around what it means, right? Is it sort of a blanket statement of don't go in there and don't talk to don't stimulate this patient in any way, or is it really that we're scheduling stimulation and scheduling rest? So I think, and I also think that term is kind of derived from more severe TBI kind of history, right? Where you have someone who's in with either a structural problem with their brain from an injury, where I think that's what kind of all the rancho levels and therapeutic stimulation that all comes from. So it might be beneficial to have something that's a little bit closer to concussion, rather than kind of drawing from the structural history. It's kind of
I like it. What else? Ma'am.
Yes, so if I want to send a referral, is there an order for trauma clinics?
Well, it's Laura Harmon. We are working on it, but the computer wizards were lower on the list. So yeah, if you want to send anything, just send it to Laura Harmon. It will get to me. Dr. Marthaler also is part of the trauma clinic too. So if I am not available, he is there and well versed. Okay, what else? Okay, thanks for coming.